How are we reperfusing our patients in real life? Lessons from the registries and targets for improvement. That's all.
Thank you very much. It's a very pleasure to be in this almost last session, and I want to thank you again for all of your hospitality and to the chairman of this session for their invitation to participate. My topic is about really what are we doing and what is coming about from our efforts with reperfusion. There's a little overlap with what Malcolm did, who strayed a bit from the pharmacoinvasive, but I think I'll give you maybe a little different perspective on what we're doing in the U.S. I wanted to pick out 5 topics for which there is recent interest, new information that's emerging, and some controversies that are occurring to stimulate your thinking about what's happening with reperfusion therapy. And these are fairly straightforward. The first starts with this success with D2B for patients presenting to a hospital that has primary PCI capability. This is really, to me, a triumph of a change in paradigm, a recognition of the need to monitor performance. We worked together in the early 1990s, a group of us with the government, to begin to measure carefully our performance. How fast were we going with regard to the patients who would come to our front door? How long would it take to start primary PCI? At Yale University, maybe some of you have heard of it, it's a place in Connecticut, a small place. We tend to think we're very good. In 1997, it took 2.5 hours for patients to get from our front door, patients with STEMI, to get primary PCI. 2.5 hours, because people would be arguing, whose patient is this? Who's responsible? Who's going to transport the patient? People would just waste time, and it would take very long. It was only when we began measuring that we noticed this. But the very important aspect of this that is often neglected, as we started doing research into what is it that distinguishes the places that are going faster, because we discovered that there were some places in the United States that had median times that were very short. So while the rest of the country was going slow, some places were very successful in going fast. And so we began to study this. We visited those places. We tried to learn from what they were doing. We took notes. We recorded. We did qualitative research. And then we did national surveys to say what were the determinants of success. We call this positive deviance studies, studying the exemplary performers, studying the top performers and saying, what are they doing that makes them so good? Just as you might do in athletics. You see someone who's a successful athlete. You say, how did they do that? How did they become so fast? How did they become so successful? We're doing the same thing with hospitals. And we identified several different things that would make people that were associated with faster times. Things like only having to make one phone call from the emergency department in order to get everyone involved, because the one call would then go out to 6 people, and they would know this is an emergency, and they would get organized and come in and provide the care. This seems boring in medicine, doesn't it? It's not a new drug. It's nothing new device. It's not a new machine. It's better organization. It's a better system. And this is where we started thinking that good medicine is teamwork. Good medicine is working together and developing the confidence that every time we deliver the care, we know it's going to be the very top quality care, and understanding what it takes. When you mail a package with UPS or some other company, you want to be confident the next day is going to arrive. You don't have to worry. If I get on a plane, I don't have to find out who the pilot is or worry, am I going to the right airline? The performance should be good enough that I'm confident I'm going to get a good outcome. In medicine, it is not like that at all. We worry, do I have the right doctor? Do I have the right hospital? It's because we don't have the systems in place that give us confidence that there's uniform, outstanding care and outcomes everywhere. And every place has a different approach that leads to, in some cases, reinventing the process every time. This was a beginning of trying to understand we need, where there's no need for us to think every time, how should we do this? We need systems and policies and protocols we can follow, not to constrain us, but to help us perform better. And in addition, we emphasized issues like communication. In our hospital, it was common. The cardiologists wouldn't talk very nicely of the emergency medicine doctors. We would say, they don't know how to read electrocardiograms. They're making mistakes all the time. We would never meet with them and discuss those cases. Try to help learn, what is it like to be in their position? What can they learn from our perspective? How can the performance of the system be elevated? Instead, it was much easier just to make fun of them. It was much easier to joke about them and just to go on the next day and see the same performance. And the system would always continue to fail because we weren't learning together how to work together, how to ensure the performance was going to be high. I believe in the next century of medicine, it's not going to be about the star clinician. It's going to be about the star team. And just like a basketball team that has one star, they usually lose. But the team that works together, passes the ball, each person knows their role. Well, it's good if they have excellent players, but they will more often win. And if they want to be successful, we will learn in medicine, not the way in medical school where we sit by ourselves and study by ourselves, but we will learn how we work together to create more powerful performance. But we identified these in a study we published in 2006. There were innovations like this. This actually is an innovation that I learned from my friend Henry Ting at the Mayo Clinic, where that we quickly adopted because we thought it was such a good idea. Every time they did a patient who required a primary PCI, they created a report. And the report would have the patient's name, would say what time did they come in the front door, what time did they get the electrocardiogram, what time was the cath lab activated, what time did they leave for it, and what time did they get finally the door to balloon time. And then they would have the total time. And that feedback would occur within one day. And everyone on the team could celebrate the good performance. And if there was a problem, they immediately had feedback that they could investigate. Could we have done better? Sometimes not. In medicine, the care is often complicated. So there were situations where there's a good reason why it took longer, but there would be other opportunities to go faster. This is what I mean when I say we learn from each other. Henry shared this with me. Within 2 weeks, we started doing this at Yale. Now, every day we get emails. This is what happened with door to balloon time to the team, not just the team involved with that patient, but the team that's larger of anyone who might take care of a patient who needs a primary PCI. So again, we can, and then the discussions on email. Why was that long? What could we have done better? Oh, if it's a good time, people can all feel very good about it. And all of these things tend to promote performance. We did a campaign across the country where we promoted these ideas. The idea that we could work together, adopt these processes, and promote better performance together. Our goal was not to be individually good. Our goal was to say, if you are a patient in the United States and you have a primary PCI, you can relax, because if you go to a primary PCI hospital, you will know you'll be treated quickly. You will not be sitting around waiting. You will be treated quickly. And so all of these hospitals joined us through a campaign with the American College of Cardiology and also American Heart Association and 38 other leading organizations in the United States. And the hard work was done by the people in these hospitals. And I always salute the interventional cardiology community. Their work was harder to do this. And there was no more money in this. But they knew that it was good for patients, and they all worked together to provide it. And we published this paper in Circulation in last year. I'm sorry. And this is the figure from the paper, and I think this is very interesting. In 2005, first of all, in 2002, when we started studying this, only 1/3 of patients were being treated within 90 minutes. So you had a 1 in 3 chance of being treated within 90 minutes, and many patients were being treated at 2 and 3 hours after coming to the front, to a hospital with primary PCI facilities, not the transfers. You come to the hospital. By 2005, 45% were being treated by that. I showed you the article starts coming out in 2006. The campaign starts in 7, 8, 9, and 10. We are now over 90%, maybe 92% of patients are treated within 90 minutes. And I can tell you that of that last 8%, most of them have reasons for that. Some of them documented well, some of them not documented well. But by and large, if you're in the United States, anywhere you go, this problem has been fixed. And no matter what else, we have emphasized teams and systems and an emphasis on performance and accountability, working together, knowing our results, and seeking to elevate practice. So this is the first thing only to say, we might as well talk about something good that happened, and it becomes part of people's consciousness. I give this picture of this woman because she actually ended up in the newspaper in the United States, because when we published our article, they said, well, can you give us an example of someone? This woman was visiting New Haven, where my hospital is, from Rhode Island, a nearby state, and she had a STEMI while walking down the street, and was immediately attended by emergency medicine by the ambulance. Her door-to-balloon time was 15 minutes. And she came to the hospital within 1 hour because she was just close, a couple blocks away. I think only half hour from her symptoms. She comes to the hospital. She has primary PCI within 15 minutes. The next day, she has a big LAD lesion. Her echocardiogram shows normal function. She feels fine. She went home in 2 days. And we don't even know whether to tell her she had an acute myocardial infarction. Because what did she have really? I mean, she almost had an acute myocardial infarction. Now, 15 minutes is, that's really not going to be routine. But it shows that the system was ready. They heard from the ambulance. They opened the cath lab. She didn't stop in the emergency department. She went straight to the cath lab, and they quickly were able to open the artery. So let me talk about some of these issues that are being raised that I think are very important. And one is this issue that Malcolm brought up that I think is very important. If you look at trends, and this only goes to 2006, but I think it will look the same. In the U.S., the use of lytics goes down, primary PCI goes up, but the bigger story that's interesting is the number that are continuing not to be treated, which has gone down a little bit, but there remain maybe a third of patients, it seems, as recent as 2006, who aren't treated with reperfusion therapy. Now, it's not just that people are practicing poorly. These are often complex patients who have reasons why people aren't taking them either to the lab, but mostly in situations, in places where they don't have cath labs, and they have contraindications to lytic therapy. I think we've neglected this group to study them more closely, to understand what we can do. This isn't only a matter of criticizing people because they're not using reperfusion therapy. Most people, if they see a prominent STEMI, will have that reaction. But it's about, we've never really collected this group and followed them carefully. There's been only 1 or 2 studies in the literature about them. They have much worse outcomes, but they tend to be much more complex. And as our patients get older, we know STEMI is less common in older patients, but still we see STEMIs. The challenge is going to be, what is the strategy for these individuals? And in some cases, we may be missing opportunities to treat them, but in others, I think we have to begin to accept we need to study the patients with contraindications and try to understand how the quick decisions can be made about what the best strategies are. We've neglected this in thinking about the younger patient who clearly needs to go quickly and for which there's little controversy. But these patients, I think, merit our attention. I was very interested in that slide you showed, Malcolm. I hadn't seen that before across Europe. I think the variation in non-treatment suggests that some of it may be quality across the countries. But even in the countries where there's the lowest amount of non-treatment, probably there gets to a point where for some patients it's very difficult to want to give lytics, and it's hard to be in a position to take them to the lab, or there's even a contraindication even to that as well. So I think this is something worth talking about, thinking about Why aren't we studying more of these patients? Why aren't we trying to take this into consideration? The second one is the one that also Malcolm mentioned, but let me bring it up in a different way. We were working very hard on improving door-to-balloon times in the hospital. And then we published two papers. This is one paper, the first one. Brahmaji Nalamathu was the first author. The second paper was the one that Malcolm showed, which was we published that later. That was a little bit more recent. But in this first paper, we showed while we were working on this, the same kind of thing. This is earlier in time than the one Malcolm showed, but the same thing, and it hasn't improved that much. There are some patients who present with STEMI in the United States, and because we are so in love with primary PCI, as was expressed, our love affair with primary PCI might be so strong that we neglect to treat them with lytics, and we will send them for primary PCI even though it may take 5 and 6 hours before they get the primary PCI. We are blinded by our affection for the intervention. How can the patient now, 5 or 6 hours, derive benefit? It's not primary PCI anymore. But this is what we've thought. We've got to move them to the major centers and go. And this is extraordinary, really. And like I said, we repeated this in a more recent study. And this led us to think, how can we be accountable for this? Because it turns out to be more difficult than you think. In order to know the door-to-balloon time from first hospital through the second hospital, I need data from both hospitals to combine. Now, in a registry like this, we were able to get data from both, although it was reported by the second hospital. But we had to think, if we require hospitals to submit data, 2 different hospitals submitting, it's going to be very difficult to merge the data. I mean, this is just a technical problem in measurement. And we thought, what should we do? And we came up with this idea of door in, door out, that we at least should have the first hospital should be responsible for making a quick decision on transfer and having the patient leave the hospital quickly. And that was how we developed that measure, which the government has begun collecting and will report. So now the hospitals that were transferring, before, their performance was invisible. You didn't know how long it took. They didn't have any accountability. They could take 4 hours to transfer a patient, and it would never be known. This is what developed into this national measure, which the one that Malcolm showed was from 200 hospitals. It's about 250 hospitals participating in a registry, and that was what the second hospital was reporting. That's good, and it was very close to this. This is the actual national data from the government that is being reported by the hospitals. It's mandated. They lose money if they don't report this information. Not for their performance. They don't get paid for performance, but for reporting so that everyone can know. And as I said, it's the time from arrival of a patient with STEMI to departure to a hospital to perform a primary PCI. And this is what we concluded. The time, just as Malcolm did in the smaller group of hospitals, the door in, door out time rarely met the recommended 30 minutes. And this is from all hospitals in the United States. It was with more than 5 cases that transferred out patients for primary PCI. And again, you've got these hospitals that are this is more than 2 hours. More than 2 hours to leave the hospital. That doesn't count the transportation time. That doesn't count the time at the second hospital. We discovered this is a point of where there's maybe the most opportunity for improvement. And we also discovered the 2 hospitals are often not talking to each other. That even when they come to the new hospital, they start over in their evaluation. They're not ready to say, here's the information, now let's go. And this began to have us thinking about how these, as a system, remember I told you the cardiologist often doesn't talk to the emergency medicine person. Well, it also turned out that one hospital doesn't give information back to the first hospital. First, in the United States, we don't want to offend them. So we don't want to tell them they're doing a bad job because they may not send the next person to us. So we are just quiet. But that doesn't make good teamwork. And so we're starting to say the teamwork now needs to go across hospitals and be more integrated. We looked at it by states. We have some states that are working very hard on this transfer. North Carolina, 50 minutes. Minnesota, as you heard from Malcolm, it's between Mayo and Minneapolis Heart. They are the leaders. They're some of the leaders in the country in this. And as expected, they are some of the fastest door-in, door-out times in the country. Still, you would like them to go even faster, because if they take more than about a half hour, it becomes very difficult to do the primary PCI even within 120 minutes, total door to balloon. But still, in these states where they're concentrating and working on it, they're doing very well. In states where they're not, they can be taking almost 2 hours to have the patient. Median, half the patients are taking more than 2 hours almost to get them out. This is showing you that the quality matters. This is showing you that working together makes a difference. In the states where they're working together, they're going so much faster. Less than half the time it's taking for the places where they're not concentrating on it at all. This again is medicine in the next era. I saw an interesting article in the New England Journal of Medicine by Brownwald and Nabel that showed the reduction in mortality from coronary heart disease. And they also reflected on the reduction in AMI mortality recently. And do you know that we've had no new real breakthroughs in AMI in the last 10 years? But our systems are starting to get better. The breakthrough in the last 10 years is systems. It's working together better. It's higher quality care. And you can see what we want to do is push all of these states up to what a state like Malcolm is doing. Why should he only be talking about the Mayo Clinic? He should be saying, anywhere you go in the United States, they have this kind of system working together. Mayo, great, but it shouldn't be exclusively Mayo or Minneapolis Heart or any other hospital. This should be what patients can depend on no matter where they live. They shouldn't have to be lucky where they live. They should be able to be confident in a healthcare system that's responsive and performs well. False activation. Well, as I said, the interventional cardiologists have done a remarkable job leading with nurses and technicians and ambulances and others. But the interventional cardiologists could have killed this idea because they really were the people who are seen as the leaders, and they needed to be supportive, and they were. But the bane of their existence is the false activation. No one likes to have the system work perfectly and have to come in the middle of the night and discover maybe it wasn't necessary. So there have been some articles on this false activation issue. There was an article from Minneapolis, and they looked at about 1,300 patients. And they said that the combination of no culprit artery with negative biomarkers was present in about 9% of their patients. And then there was another paper, the frequency of false positive cath for suspected STEMI is relatively common, is what they said, 9%, because they're interventional cardiologists, so 9% is going to be very annoying, and that will be common for them. But then this article came out just this week in Archives of Internal Medicine from 2 hospitals in San Francisco. And they said that they looked at only 411 STEMIs, and they said 36% were false activations. And so this is an interesting question that I think raises something even bigger than this issue of false activation. They said, by the way they did it, and same with the Minneapolis study, false positive activation was defined as lack of a culprit lesion by angiography or by assessment of clinical electrocardiographic and biomarker data in the absence of angiography. Let's take this out. Some of these patients didn't have angiography, and when they looked, they said, well, we disagree with the diagnosis. Maybe it's not STEMI. That was a very small number. The big number was the number of patients without a culprit lesion. Now, my question is, you have to think about this. Is this false positive activation? Is it false positive STEMI diagnosis or false positive activation. Is it bad decision making, or is it that we have to get better at determining which patients who present with traditional electrocardiogram and symptoms of STEMI actually have a thrombus, actually have an occluded artery? You know, this whole idea came from the early lytic trials, where subgroup analysis showed that STEMI ended up being the area where lytics were effective. But maybe we need to do more work to be smarter about which patients presenting with STEMI need to go to the cath lab. But we'd have to have a very high sensitivity and specificity in order to be sure that we weren't going to miss patients. But I think this is raising less about bad decisions, because these are patients with ST elevation and reasons to go to the cath lab, but it's an understanding that many of them won't have culprits. Now, they could have lysed spontaneously, or some of these people were cocaine users. They may have had spasm. There may have been other reasons. There may have been even some mistakes. But this is just raising questions about how do we get better, because you want to lower this rate as much as possible. Unnecessary testing, stressing the system for little gain in this area. And so finally, concerns about the impact of door to balloon. There is an emerging controversy, mostly started by Hitinder Gurm at Michigan, who raising questions about how fast do we really need to go, and how much are we gaining by going so fast. Now, you know the curve flattens out as you get really fast, and it also depends on when the occlusion occurred, how much time has occurred. So the system delay and the time to notify the system, how long were the symptoms present, all play a role. Probably only a fraction of the patients really depend on fast door to balloon time. Some of them may not, because the symptoms have been going on so long, or the delays in the system have been so great. And we need to be accountable for this too. I talked on Thursday about surrogate outcomes. The shorter door to balloon time is not the outcome. It's the mid-performance. We need to be confident that shortening that time is actually improving outcomes for our patients. We need to be understanding which patients really depend on us to go fast, and to concentrate our resources and efforts in that area. In the absence of being able to identify those patients, we're better off having systems that treat everyone quickly. No one wants to spend time in the emergency department and just waste time. But this is going to be, I think, a continuing question and issue that will be coming up. Tracking mortality from primary PCI patients versus all patients also. Most of these are looking at what is the trend for mortality among primary PCI patients. But at least in the U.S., we're taking very different patients for primary PCI today than we did 10 years ago. And we need to be sure the adjustments are correct. So there's a lot in this. But the bottom line is we need to be accountable. Are we really improving outcomes for our patients? So these are just, I thought, 5 areas that are worthy of some consideration and are bringing up issues in the reperfusion time. Thank you.
Thank you, Harlan. One of the American ways to improve the results is to pay not for procedure, but to pay for, let's say, the results, so pay for performance. But does it really have a good results? Do you have experience on that?
Well, there are 2 parts. One is actually in the United States now, there is a focus on payment for results, and the AMI mortality rates are part of a package of measures that will be used to determine reimbursement to hospitals. So the first part of the question actually is there is a movement towards focusing on outcomes, and the outcomes of AMI, the actual mortality rates, will be some subject of what they call value-based purchasing that will be part of it. But are you asking about the door to balloon?
Yeah.
Well, like I said, I think there are many of us who believe that more rapid treatment, better teamwork, more coordination of care does in fact improve outcomes. But largely it's based on the kind of graph that Malcolm showed, where he's showing that, he showed it with the door in, door out, but it's that shorter times are associated with lower mortality. But a better demonstration would be the change in time showing change in mortality. And we haven't yet got the best database to do that in. So the truth is we are in great need of data. Maybe in Spain you have some that shows that the change in time is being associated with, on a national basis, with a change in the mortality for these patients. And we are lacking that now. And most of the databases, even the ones that are being published, have some critical limitation that makes it difficult to draw the inference in the end.
First of all, it's an outstanding presentation, but it's a question regarding the false positive activations. In Spain, we have 3 networks that have years working. One of them is from Galicia, and they reported a 7 to 8%, much lower than the 36. This for me raises the question of what people is in charge of doing the activation, the education, the training of these people. All the patients have to be seen by EKG, by any technology like iPhone, to be transferred to a cardiologist to see the EKG. What kind of idea do you have about this?
Yeah, that's a very good question. What system should we use? Who gets to activate the lab? And how can we begin to ensure that that performance is good? I think, by the way, that even the 36th, let alone the 9%, that a very small percentage are misreading of the electrocardiogram. Again, these patients, when they reflected back, most of them had ST elevation. They just had no culprit. But there is no agreement. I mean, some people are taking pictures on their phones. Some people have actually more expensive systems in the ambulances. Some don't have the ambulance systems. We're trying to drive towards standardized ambulance systems. And then we are allowing the emergency medicine doctors to make the call. And then it's up to us to work together if are mistakes, for there to be education around that so that people can learn from it. But I don't know, Malcolm, in your experience, what do you think?
Yeah, so I agree with everything you just said about the defining what a false activation is, and I think you've summarized it very nicely. But in terms of the interpretation of the ECG, in our experience, what we've done, we also have a pre-hospital activation of the cath lab by our ambulance service. And I believe we give them 2 afternoons of ECG training. And our paramedics now with that actually probably do better than at least the emergency departments in the rural communities. And I'll come back to that in a moment. But we don't use any wireless transmission, no iPhone transmission. And our false... let's say a misinterpretation of the ECG from the paramedics is probably under 10%. So they do a very good job, and we give a lot of positive reinforcement when they come. Now, in terms of the emergency departments in these smaller hospitals, as cardiologists, sometimes I think we are too demanding. And Harlan, you brought up nicely at the beginning, we were being critical of our colleagues in the emergency department. And that was assuming we even knew who those colleagues were. We haven't really worked with them very well until the last 10 years. And we're working in the same hospital, and we had no idea who that person was. So we didn't have good teamwork. But now in these smaller hospitals, and I have all the data for these hospitals, and you look at they may see 10 STEMIs a year, but they may have 10 staff who are rotating through these hospitals. And so these are not cardiologists. So they may get to see 1 STEMI a year. And maybe we're being too optimistic that they will have the capability of interpreting an ECG accurately, particularly the ones that are not so easy. And I think that we just have to be honest about that. And this is where I think that in terms of transmitting the ECGs, I think this would be helpful. But the patient's being transferred, and then we have the ECGs faxed to us. But I think there are technological advances we can make. But I'm not sure I would institute in the ambulances at the moment. I think you can train them pretty well.
I'd like to comment on one of the points you raised in your presentation about where would you put the cutoff to decide where to go for a invasive strategy or a primary PCI? Because in the context of trials, in the context of very dedicated registries, you've shown very nice time for transportation from one hospital to the hospital where you have the facilities to undergo to take a primary PCI. But in real life, it's not always the same. So would you go for 90 minutes
You've just asked the most difficult question, which is, how, just as you've said, how long is too long? And when should they not be transferred, or should they at least be treated with lytic therapy, fibrinolysis, in the first hospital? I can tell you on the STEMI guidelines, this was the most contentious topic. We spent a lot of time talking about this topic. And in the end, we settled on 120 minutes. But it was a compromise discussion. And I think that more what we were saying was we really should focus on the patient and decide if it's a patient who's got some contraindications to fibrinolytic therapy, then we should tolerate a little longer time. If it's a patient who looks sicker and is suffering the effects of the occlusion and is extraordinarily high risk, then maybe the transfer time will be damaging and they need to be treated immediately. It was a matter of trying to weigh how long did they take to come in. There was really, in the end, no good answer to it. And we were able to say, when it's 3 hours or 2.5 hours, or to do it, it's too long, really, unless there are pure contraindications to fibrinolytic therapy and you have no choice. And even then, you should have a system that's more responsive than that. But I don't know, Malcolm, I'm interested in your thought, but we debated this for quite a long time, and about 2 hours, but then most importantly, looking at the patient and trying to figure out, is this a patient who is essentially demands our intervention now, and we can't wait? Or does it look like they're stable enough that they may be able to tolerate that and avoid the risk of bleeding and have the more definitive procedure immediately? But Malcolm, what do you think?
I think pretty much the same. I mean, we talked to, I think both of us emphasized that these patients who present early, these are the ones that have the most to gain. And I think that that's where it's important to have a very clear protocol and not have too much flexibility, because otherwise you're going to have eminence-based medicine take over, and then we'll have these long delays. But, the 90 versus 120 minutes, we've wrestled with that. But I think in any network of care, I mean, it's got to be an organization. I think you emphasize the importance of being able to talk to the cardiologist. So in our own system, when we have these patients that it's not quite clear what to do, particularly once we present a little bit later, we will then have the emergency department physician at the other hospital talking directly with the cardiologist and then making a decision based on that individual patient. So we allow some flexibility in the system, but we try to minimize it if we can.
Will you ever, let's say it will take you, 100 minutes to do it. Will you ever tell them, please, just go ahead and give them fibrinolytic therapy now? When will you decide to say that to them?
Well, we try to follow the protocol. So,
Yeah.
I mean, they have the exact, I didn't show you a picture of that protocol, but they have the same protocol in their emergency department as I have in my pocket. And we just follow the protocol. Because the problem here is that you think it might be 100 minutes,
Yeah.
but until those dido times can clearly be demonstrated to be shortened, and there are other things that may be unforeseen, that there are delays. And next thing, you think it's going to be under 90 or 100 minutes. Many of my fellows say, but this town is only 80 kilometers away. We could have done this quickly. And I show them the data, and we find that more than half the patients is going to be 150, 180 minutes. So that's why I think it's good to have a system in place and follow the protocol.
So I think that's important, that there's not too much deliberation. People know what to do. But the second thing, I want to say something about Mayo, that in the U.S., it's uncommon for the receiving hospital to be encouraging those other hospitals to give fibrinolytic therapy for some of those patients. And really, you're setting, I think, a good example of where that therapy really can help.
Getting back to Dr. Bell's talk, but probably one of the most important cons of the pharmacoinvasive strategy is rescue angioplasty. Leaving aside patients who don't need rescue angioplasty, results of pharmacoinvasive strategies is excellent. But when you look into the hearts with cardiac MRI of patients who have had undergone a rescue angioplasty, well, you find severe areas of microvascular obstruction. You see huge areas of hemorrhage, zero myocardial salvage. So, what can we do to improve management of patients with rescue angioplasty?
Well, I think the important point here again is to have a system in place and actually probably take the patient to the cath lab sooner rather than later, just as was shown in the pharmacoinvasive trials. And in fact, we don't really like to use the term. In fact, the college guidelines now actually trying to dissuade us from using the term rescue PCI and facilitated PCI. So I think the important thing is get the patient to the lab routinely. If it turns out that they reocclude or did not reperfuse initially, that's part of the pharmacoinvasive approach. And I think we're doing better now than we have in the past, and I think that we have good data to support that.
Thank you very much. We have to follow.